Well, good afternoon, everyone, and welcome to the Regional Rounds hosted by the Regional Geriatric Program of Eastern Ontario. For those of you who don't know, my name is Matt Sekeli, and I'm the Manager of Education, Knowledge Translation, and Research at the RGPO. And it's great to have you all join us again, some in person, some online. Just going to, as people are joining online, I'll just remind people of the Zoom or Teams etiquette. Please just mute your microphones when you're joining, and you can feel free to keep your cameras off. There'll be a question and answer period at the end as well, a chance for people online and in the room to ask some questions. So we're thrilled to bring these rounds back as education, collaboration, and innovation are really central to the RGPO. And our hope is these rounds are a chance for us to integrate together, connect and collaborate, and support each other for caring for people throughout the region. These rounds are designed to be interdisciplinary, so we've brought in perspectives from geriatric medicine, geriatric psychiatry, care of the elderly physicians, allied health, and many more to ensure this inclusive and relevant topics. So with that in mind, if you have topics for us that you want us to cover in these rounds, please feel free to reach out. I'll put my email in the chat for those of you online, and my email will also be shared at the end of the presentation. I also want to thank all the partner organizations that made these rounds possible and the members of the RGPO Education Advisory Panel for their help and advice on these rounds. Given that we're relaunching these rounds, we want to welcome everyone back to this new hybrid forum, and we'll be also taking this on the road. We'll be going to different partner organizations and sites as well to share these at other places. So please feel free to join in and share these rounds with as many people as you think are relevant. So with that, I want to welcome today's speaker. This is a close colleague of mine and someone who's taught me a lot about dementia care here at the hospital, Jennifer Coop. Jen is an advanced practice nurse here at TOH, working in the Division of Geriatrics with a specialization in dementia care. She first got into geriatrics as a GEM nurse in the ED and later joined the inpatient geriatric medicine consult team. She also completed a master's in nursing with a focus in leadership with special interest in delirium and patient and family education. She's applying those practices in her current role and is committed to improving outcomes for people living with dementia through advanced practice nursing, program development, consultation, research, education, and leadership. She leads the Dementia Decoded acute care dementia strategy, which you will all learn about today. And I'm thrilled to have her speaking with us today. Please join me in welcoming Jen.
Hi, everyone. Thank you, Matt, for that kind welcome. I'm happy to be here with all these friendly faces in the crowd and also to those of you who joined online. So I have the pleasure of sharing our acute care dementia strategy, which is really the work of many people here at the Ottawa Hospital, as well as the Regional Geriatric Program and our community partners. So I'm happy to have the pleasure of sharing this on behalf of the team that's really come together to make this a reality. So we all know that our population is aging, and so this means that there are going to be more and more people living longer with dementia in our care. CI-high data across Canada has shown that people living with dementia have higher hospitalization rates compared to those without dementia. We know additionally that when individuals with dementia are hospitalized, they face more negative outcomes, including longer time spent in the emergency department, longer hospital stays, and are more likely to experience harm. Also, according to the CanAge report in 2022, Ontario is ranked in the bottom 2 provinces for dementia preparedness in the country. So one of our geriatricians, Dr. Frank Mullner, here at the Ottawa Hospital, wrote an editorial that really emphasized the need for a plan for caring for people with dementia, especially in acute care. And so in the fall of 2021, a number of invested people from geriatrics, geriatric psychiatry, and the regional program came together at TOH to review the literature, the best practice, analyze the current situation, and make a plan for how we might start addressing the needs of people living with dementia. And part of this scoping phase of the strategy design included interviews with interest holders, such as healthcare workers, hospital leadership, patients, of course, and their care partners. And from these interviews, these word clouds were developed. And so what we've heard from patients and families was that there was a lot of frustration, that they were scared, that they were confused coming through the hospital. We also saw from our staff that there was a sense that they felt unable to provide the care they would choose, or that they felt patients deserved here in hospital. And we also saw that there was a great risk for moral distress as well in the care they were providing. So in the acute care setting, we're all too familiar with the challenges we face with alternate level of care rates rising. And this is meaning that there are more people in the hospital awaiting a safe discharge plans who may not really require that level of acute care. And so then this leads to backup flow of patients through the system. And so we see things like ED overcrowding. We know that this type of environment really tends to trigger more responsive behaviors in people living with dementia. So this leads to poor outcomes for patients. We see delirium, higher restraint use, other complications and falls in hospital with this population. This leads to costs for needing sitters, equipment, overtime, absenteeism, injuries to staff. And so in general, we see that there are poor patient experience, that feeling of that scariness and frustration, and that staff moral distress of frustration as well. So how can we make this better? So the original strategy identified these following key components. We knew that we needed that strong interest and commitment from our senior leadership. We needed data to show what is the situation, what are the needs, really prove our case, and also be able to, in the future, show improvements when we address them. We knew that staff needed support and education to build capacity in dementia care, and we really wanted to support patients and families to have a better experience here across the system. So the next step was, how do we operationalize this strategy? So there was a great deal of work done to develop a high-level theory and logic model to inform the evaluation plan. But we also really needed to be clear and establish, what does excellent dementia care look like at the Ottawa Hospital? And what are we asking our healthcare professionals to do differently to provide that care? So we gathered an amazing working group together, and myself and Heather McLeod, who is our former knowledge translation specialist. We worked together to do this with great support from the quality department at TOH. And so we brought together a diverse group from the Ottawa Hospital, frontline staff, interprofessional staff, and leadership, as well as community partners, and most importantly, people with lived experience were involved in that process. We did process mapping exercises. We looked to the research, we looked to best practice, we looked to our clinical experts here at the hospital and their experience and what they saw to be true and things that could be improved rather. And we basically came together and were able to establish some tangible steps for improving dementia care, and highlighted some key elements of what we're calling the dementia care pathway that we wanted to implement. So we rebranded at this point as Decoding Dementia, and we established these three main elements that we wanted to emphasize, which were, how are we going to identify people living with dementia and ensure that we had person-centered care that was really proactive to manage functional decline and ensure sustainability of the healthcare system. We felt it was really key to also align with the newly updated TOH corporate strategic framework as well. And we're able to connect these elements to the key elements, the key parts of the strategy, including enriching quality of care for patients, igniting the power of people, nurturing our social responsibility, and accelerating discovery with innovation. We felt that this alignment was crucial to establish leadership support and make improving dementia care at TOH a real priority. The goals for the strategy were also in line with the quadruple aim framework that I'm sure you're all familiar for healthcare improvement, that really focuses on better health of populations, better patient experience, better experience for providers, healthcare providers, and better cost efficiency. During the process of identifying these elements, we were quite aware of the existing policies, practices, and priorities at the Ottawa Hospital that were already in place and that we could really build on as a foundation. We established linkages and partnerships with things like the ALC leading practices and ALC strategy at TOH. We already had really robust policies related to delirium at the Ottawa Hospital, least restraint, and fall prevention, and other policies that we could draw and build on. We had a new electronic health record that had a lot of potential and possibilities. And there was also work being done to build our interprofessional corporate education strategy and the nursing strategy. And we knew that finding these opportunities to align and collaborate would help us really incorporate the needs of people living with dementia and increase the impact and chances of our mutual success. So next I'll go into more details of the different working groups that we had established. So the first was documentation and data, and this was led by Maris Pryor, a manager from the RGPEO, and also Dr. Frank Malner, a geriatrician at TOH. And the purpose of this working group was to be able to measure the impact of the strategy and to align to what is important on a corporate level. So there was work done by the analytics team, departments of medicine, and members of our dementia strategy to build this dementia dashboard. So it pulls together many sources of data from our electronic health record, our finance dashboard, and it provides a snapshot and also a big picture to show change over time as we implement elements of the strategy. So you can see there's information about cost per case, comparing patients living with dementia in our hospital to the larger population at our hospital. So you can see there's increased cost per case, changes in ALC, and various other measures that are very important. So it really did provide the same picture that we're seeing from that CI-HI data in our local context. And the same issues were indeed happening here. So we're seeing longer lengths of stay, more likely to experience adverse events, 30% proportion of ALC days, and a 1.8 times greater cost per case for patients living with dementia coming through the hospital. So we knew this really did show and kind of put money where our mouth was, that there were these issues and we did need to come together to find a solution. The next group was focused on identifying people living with dementia coming through our hospital and associating that personhood information. We wanted to develop a process within our electronic health record so that every encounter with the Ottawa Hospital to encourage staff to engage with the patient and their care partner to gather that individualized behavioral and care needs to inform patient-centered care. So myself and my colleague, Courtney Munch, were leading that working group together. We had some great inspiration from the Top 5 program that was funded by the Australian government, where they did a similar initiative engaging with patients and families to identify 5 key strategies to incorporate for people living with dementia coming through their hospitals. Also, we connected with a group in Wisconsin, the University Hospital, who also uses the same electronic health record as we do. And they were doing a similar project, trying to identify patients in the electronic health record and incorporating that, they called it patient-specific dementia information, where they had a more detailed report about the patient. So that this key, we know that that's so fundamental to excellent dementia care, is understanding and seeing the person behind the illness and incorporating that in their care. So we were able to build something similar, learning from them and collaborating with various teams at the Ottawa Hospital. The goal was really to identify and then link staff to fill out the accessibility form, where they could include information about the behavioral likes and dislikes. So essentially, this banner and a D icon would be generated automatically when a patient had a diagnosis of dementia in their medical history or problem list. And then there was a notification to update their care needs, which then would link to this accessibility form. And you can see there was other helpful information about vision loss, hearing loss, mobility requirements, capability, communication supports. And then you can see at the bottom, we added the dislikes and likes and really took inspiration from Behavior Supports Ontario as well and other best practice, those getting to know me forms that are so popular in different settings for patients living with dementia. So the other important piece about this build was that this information stays with the patient between encounters and can be easily visible by hovering over the storyboard. So patients with dementia coming through the Emerge who had this filled out, staff could see right away what things to avoid, what things to do to provide comfort. And same could be said at the patient clinics and also in transitions to different units. This information would stay with the patient. As part of the rollout, we included these queuing questions to really help empower staff to know how to engage with family and gather this information. So when they're in the form and hovering over it, it helps them to see how they might question families and engage to get this information. We also collaborated with the Dementia Society in Ottawa and Renfrew County to sort of adapt their All About Me form. So we have a paper version as well that we could hand to families to fill out at their leisure so they don't feel the pressure and can bring that in later. And we could also put that on the head of the bed so that all staff coming in could be aware of these important personhood elements. We took great care in developing an education, implementation, and communication plan for this rollout, which happened last summer. We developed a SharePoint site for staff so they could go as a landing point to learn more about the strategy and also access different resources. We worked with the communications department to ensure that there was articles and different posts about the strategy and worked closely with the digital education team to develop a tip sheet and also an interactive learning module so people could practice how to use the ID and personhood tools in EPIC. Many of us involved in the dementia strategy went on a bit of a roadshow and did presentations to ensure dissemination about this change and to encourage its use. We also incorporated into our gentle persuasive approaches course that we offer monthly here at the Ottawa Hospital and drew attention to this change and encouraged people to use the tool to capture this very important information. For the future, we also intend to have this form attached to my chart so that patients and families could actually fill this out independently at their leisure. So that information is there if the patient were to come into the hospital. This is just an image of our SharePoint site that we created. This is the tip sheet we used. And this is the RISE module where people could go in and practice using the tool. So next, care plans was, of course, fundamental to this. We all know care planning is just fundamental to prevent functional decline and make sure we're addressing the needs and working towards the goals of the patient and their family, and really working as a team, an interprofessional team, to ensure we meet those goals through targeted interventions and strategies. We found a great opportunity to collaborate with nursing professional practice. So at the same time that we had really identified the need for harnessing and maximizing the use of care plans at the Ottawa Hospital, nursing professional practice identified the same need and had been doing a lot of interviews with frontline staff to learn that they really felt that the current care plans were not helpful. They found that it was overly prescriptive, not patient-specific, and we definitely saw evidence of shadow charting or people trying to find other areas in the chart where they could do some care planning. And unfortunately, a lot of those areas like the sticky notes, for those of you who are familiar with Epic, are not part of the legal chart. So we knew people wanted to be care planning, and they were really trying to find any way to do it. So we were happy to collaborate with professional practice to kind of develop the ideal scenario of a care plan that could work so much better. And we knew that this would really help our patients living with dementia as well in hospital. We wanted to make them patient specific, of course, meet the documentation standards of our colleges. Interprofessional collaboration was very key, and making sure that this information would be communicated well on transitions was also very important. So the goal was really proactive person-centered care to support remaining function and prevent harm and adverse events like delirium, falls, and restraint use. So it follows the typical assessment, diagnosis, goals, intervention, and evaluation framework for care planning. And it really encourages our care teams to be detectives, carpenters, and magicians. So we need to gather the information like a detective through our assessments, gathering personhood likes and dislikes. Then as a team, being carpenters and building this care plan of how do we meet the patient's goals? How do we address their needs? And then finally, a little bit of magic, be magicians, that teamwork and using those specific likes and dislikes, those gems that we learn about the patients, like their favorite music that calms them down and the favorite snack or ice cream to help take the medications, incorporating those elements to make it really person-centered care. So the care plan itself that we built, that we have built and are almost ready to launch and trial, really had these three main elements, and we wanted to keep it open and mostly free text so that it could truly be individualized to the patient's needs. The focus issue, triggers and contributing factors, and then interventions and strategies. So this work could be done in the care plan activity, and then a report would be created on the summary so that it functioned as the old Cardexes that people really enjoy, that where the care plan was, when we used paper charting, could capture all the important needs and plans for the patients. We wanted to recreate that. So just as a quick overview, the focus and issue, and I should say, the care plans were, the ultimate plan is for it to be rolled out across the organization for all patients. But we were really focusing in as the pilot dementia care plan to trial the structure and also the education that's needed initially. So the two main issues for the dementia care plan were focused on supporting function and also the needs of the patient and addressing any responsive behaviors. We looked to the PIECES framework and the A's of dementia and delirium and other elements that we know can trigger and contribute to some of the challenges or issues that we see in hospitals for people living with dementia. And then wanted to address the contributing causes and to resolve the issues of problems and help the patient reach their goals through these interventions and strategies. And again, highlighting the importance of the interprofessional collaboration, and that also includes the family and the patient in that care team as well. So we know going forward that these care plans will need education around sort of the process for care planning and general information around that, but also specific to dementia care for the needs and assessments and interventions that would be needed for those patients. All right, and then next is our champion and education program. So this is being led by Nadine and Dr. Matt Kelly. And the purpose is to develop the Dementia Decoded Champions Training Program to enhance dementia education that's sustainable, that continuously supports and empowers staff to recognize and care for people living with dementia, and create an environment that promotes best practice and high quality dementia care. So again, the working group came together to identify this sort of three-pronged approach. We also had the pleasure of meeting with the two leaders of the Scotland Dementia Champion Program. That was a countrywide program, and Matt and I were able to meet with them, which was really quite a neat experience. That program's been going on for decades, and they had so much to share from their experience, and so we learned a great deal. So recognizing that we need some general education, so information about our strategy for our staff at the Ottawa Hospital, but also empowering select people to be effective change agents across the organization as champions, and to develop those skills through continuing education. Leadership empowerment was also really highlighted from our colleagues in Scotland, as they identified the leadership as really sort of sustaining those change and helping their staff to put the dementia care into practice. We also wanted to look to existing clinical expertise at the Ottawa Hospital and sort of to upskill those groups that already exist. So we know we're very privileged to have specialized geriatric teams at the Ottawa Hospital through our dementia behavior support team, geriatric medicine consult team, our geriatric emergency management team in the emergency department, and also our geriatric medicine unit. We also identified throughout the pandemic and beyond, there's been a number of projects to support novice nurses on the unit. So there's clinical coaches who are retired nurses coming back to provide support, as well as clinical nurse experts and clinical scholars. So we met with these groups to provide education about the strategy and ways that they could support frontline staff to use some of these tools to enhance the care of people living with dementia. As I mentioned, we also enhanced our GPA program with this information and incorporated this learning into corporate orientation as well. So next is to pilot this education on an identified unit. And so we've highlighted our geriatric unit as the first pilot, providing what we're calling GPA plus. So it's gentle persuasive approaches plus all these elements of the dementia strategy and the care plan. And also enhancing champions on the unit with harnessing the LinkedIn learning sessions that the Ottawa Hospital has recently acquired. So these are other sort of leadership training skills, implementation skills that we hope to roll out next. And then empowering our leadership on the unit. We were able to send a CCL manager and nurse educator to PIECES training, and then also enroll them into the implementation certification to help really roll out some of these elements onto their unit. So far, we did receive some funding to train the nurses on our geriatric unit, and we have been using the confidence in dementia scale, and we found measuring pre and post implementation of the education that there was a 25% increase in confidence in caring for people's dementia. So we were pleased with the impact of that and hope to recreate that on other units as well. We also plan to develop a continuing interprofessional education dementia day. We've been collaborating with the U of O Skills and Simulation Center, and we also met with some colleagues at Sunnybrook who had done a similar simulation day. We were able to also purchase these simulation suits that allow healthcare workers to experience some of the impairments that can come with older age. So for example, the glasses provide opacity so that the eye lens, narrowing of the visual field, high frequency hearing loss, head mobility restrictions, joint stiffness, loss of strength, things like that. So our healthcare workers can kind of experience what it's like for our patients, and hope to do sort of a half didactic teaching day followed by a case-based role play and technical skills in the simulation lab. And we intend this to be interprofessional education opportunity. So we're pretty excited about that. So it is helpful to take stock and look back at what we've accomplished. It's been, over 4 years, quite a journey so far, and it's nice to see a few of those green check boxes. So we've accomplished some things and still have more to go. But this is really a testament to the collaborative work and all across the organization with the regional program and our partners in the community working together to make this real change. So over the years, this kind of shows how it's evolved in terms of the working groups. So each time there's sort of a new iteration of what we're working and focusing on. So you can see here that we went from the ID personhood, care plans, champion program, and documentation. And we're working on now the pilot program and developing what our champion program will look like. As I mentioned, the simulation continuing education, and then also looking to expansion. How can we partner with other organizations, other partners in the Atlas Alliance using the same electronic health record, and really partners in the region to expand this work and learn from each other and improve the care beyond just our hospital. So I thought it'd be helpful to share a few lessons learned along the way. Some of the facilitators were certainly, as I've mentioned throughout the presentation, engaging a diverse team, and especially including people with lived experience. It's been, very eye-opening. As a healthcare worker, you definitely have this one perspective, and it's so helpful to bring in patients and their caregivers. It's a very refreshing look and really helps to focus in on what's most important. I think being open to collaborate and really looking for opportunities and grabbing onto those as they arise. We know that the healthcare system is constantly changing, and especially in acute care, it's a rapid pace. So really jumping on those opportunities as they come. It's been very helpful, definitely, to align our priorities with the organization to really get that leadership support and put the needs of patient living with dementia on the map here. Another big important part is data, right? We have to show the need and then show that we're making a difference. So having that evaluation plan and being able to measure impact from the get-go has been super important. And then just being agile and persevering. There's always going to be bumps in the road and some no's when you'd really like yeses. And we just have to persevere and sort of keep our eye on the prize, if you will, knowing that it's our job to really advocate for people living with dementia to ensure that we're providing the best care possible. And then barriers, of course, time and money. Isn't that always the case? Certainly, when it comes to education, you do need that funding to pay for people's time, to have the resources to do that. So, Matt's been instrumental in trying to identify different funding opportunities and putting in requests and grant proposals. So that's been very challenging, but also a very interesting part of the work. Another, as I mentioned, the data was really important, but we definitely can see that there are some challenges with the accuracy of some of the data, especially if it's being inputted at the bedside. Is the CAM tool being used properly? Are we actually documenting when restraints are being used? Things like that. And also being really mindful of like what data is important to capture, what's really giving us the story and showing the impact of what we're doing. So that's been a challenge as well. Getting buy-in, of course, is always challenging. So trying to get people to see the need is really key. And also getting them involved from the very beginning so they feel like they have a voice and are shaping the care that we're going to be delivering. I think another big barrier is trying to seek perfection. It's just not possible. You could just kind of got to start. This is what we have. We're going to go with it. And then evaluate, see what's working, what's not, and have that iterative approach to tailor it to the needs as we go. So in conclusion, I think we all recognize that the journey for someone living with dementia and their care partners is complicated and challenging and difficult to navigate. And those of us who have experienced that personally as well with our family members can attest to that. And all of us in this room and on the call, we play a role in that journey for patients and families. So we wanted to share this work that we've done to see if there's other opportunities to collaborate, to share from what we've learned, build on each other's successes, and hopefully make that journey better for our clients.
So with that, I just want to remind everyone of our next session on June 3rd. This one's going to be focused on geriatric mental health with a specific specialty on sexuality, and it's going to be Dr. Soo Jin Chun from the Royal. So please register for that and either join us in person or online. And I also see that there's a number of questions about sharing the slides. There'll be a recording of this posted eventually once it gets processed. So thank you very much for attending, everyone, and have a great rest of your day.